peer-reviewed publications in local and international journals. So join me in welcoming Dr. Tonia Onyeka for our presentation. 40 minutes, please, ma'am. Thank you. Over to you, Dr. Onyeka.
Thank you so much, Dr. Rotimi, and welcome everyone to the 8th session of the webinar series of the Nigerian Society of Anesthetists. Today, I will be discussing the topic that says the anesthetist's role in disaster management. And I know most of us will be keen to find out what role do we actually play whenever there is a disaster. But before we get to that, there are just a few things that we need to understand. According to the World Health Organization, a disaster is a sudden event causing severe destruction of infrastructure, people, and the economy, and which overwhelms resources of that country, region, or community. So we can have various forms of disaster. Now, the origin of that word is actually from Latin. Dus aster, disaster. Dus meaning bad and aster meaning star. So bad star. So when in the ancient times, when people wanted to refer to a bad omen or a bad event, they said the person has a bad star. Sometimes, some people still do that. Say, okay, if you have something befalls you and it's not pleasant, then you say your star is because your star is bad. So that's the origin of the word. And then it has, of course, Italian and the French versions. The earliest recorded account of any disaster in humanity is the account in the Bible and, of course, in the Quran. And that's the account of the Great Flood during the time of Noah, that God instructed Noah to put his family, his wife, his daughters, and their husbands into a specially crafted ark or boat to take him for the duration of the disaster. So this is the earliest form of documentation for disaster for humanity. And it was a natural disaster, and it lasted 30 plus days, about 40 days. That's a month and 10 days, and that's a long time. So what else can we know about disaster? Disaster has a classification, like many things in medicine. And even though disaster is not medicine, disaster has a medical aspect, okay? And the classification of disaster can be either by definition, so it can be natural, where there are natural causes, and then it can be man-made disasters, where the causes are as a result of the interactions of humans. So for natural disasters, there are a lot of things that come there. You're talking about climate, you're talking about things like the flooding, and then when you talk about earthquakes, that's geophysical, then biological, things like the pandemics, Ebola, and what we currently have, the pandemic we currently have now, which is the COVID-19. So some of these are disasters that can come and they wipe out economies, and drastically and negatively turn the fate of people around. So these are some of the examples that we can see. I mean, for many of us, the ones that are very familiar, the flooding and the building collapse and the airplane crashes. Of course, a lot of the times you can have fires in markets, fires in residential places, bomb attacks, and then of course, earthquakes and landslides. Now, the different types of disasters have different patterns of mortality and morbidity, and that is important for every clinician, including us, the anesthetists. For instance, when you have earthquakes that occur, especially in urban areas, there's usually a high ratio of injury to death. So you can have a ratio of 3 injuries to 1 death, but that's different from flooding, where you have 1 injury and 9 deaths. And the reason why you have this disparity between the ratio of injuries to death and the type of disaster is with the mechanism. For instance, for flooding, when people are injured and they get they're injured maybe by the debris of the flood and all that, that is an added morbidity to them. So in addition, without the injury, they would have drowned. The injury may make it faster. So that is why for flooding, the deaths are usually more than for earthquakes. What are the accounts of the disasters that we've had in Nigeria? As you can see on your screen, there are a couple of them, but of course, the most recent, which is still ongoing, is the conflict we're having in the Northeast. And that has brought about a lot of humanitarian crisis, displacement of families, displacement of people and their livelihoods. And these are some of the impacts. Whenever they occur, they're never good. They always bring about negative things. There's nothing good in a disaster. So you have massive loss of human lives, you have an increase in human suffering, there's a lot of psychological trauma, a lot of emotional trauma. People have lost their livelihoods, they've lost their properties, and many people lose their identities, invariably. And then there's an increased susceptibility to infections and disease, especially where you have flooding. Things are destroyed, okay? Facilities for toilet facilities, water facilities, things that will help you keep infection and diseases at bay is a problem. We have a typical example of Haiti, the earthquake in Haiti in 2010. After the earthquake, there was an epidemic of cholera because the infrastructure was broken down. There was no good drinking water. And then people started to catch the infection because, cholera comes with when you have poor sanitation and lack of good potable water. So people are displaced from their homes and their lands, and then invariably, all these add up to hinder national growth. Okay, so you find out that in those economies that have disasters, the gross domestic product goes down because they're spending, trying to restore lives, trying to restore properties, trying to restore amenities and infrastructure, and they're not producing. So these are some of the impacts of disaster. Now, this is a picture from Haiti, the country Haiti in 2010. I think all of us would remember they had a remarkable event. They had a disaster, and that disaster was a serious earthquake of the magnitude of about 7.3 that destroyed an entire nation, an entire island nation. And the reason why Haiti is significant in the history of disaster management is that prior to 2010, there was no organized international effort to help victims of disaster. There was no coordinated international effort. All the efforts have been happening nationally, locally. People were doing their own thing in their world when they had any disaster. But with Haiti 2010, that earthquake brought the World Health Organization to sit down and decide on what to do going forward for other communities, other nations when they had similar disasters. And they came up with a program called the International Emergency Medical Teams, okay? It is actually a program that puts together human and non-human resources to be able to, and coordinates these resources to be able to save lives and save properties during a disaster. That effort is usually an effort that is done quickly and as rapidly as possible to ensure that a lot of lives and properties are rescued and are protected. As you can see on the screen, there are five teams. So where does the anesthetist fit? The anesthetist fits into type 2, because in the type 2 EMTs, they provide emergency care, which includes surgery. And some of them have small ICUs in them. So we're in type 2, we're also in type 3, because the type 3 EMTs have facilities that can replace tertiary health institutions. Now, this graph we're looking at is a graph that shows the coordinated responses to earthquakes and tsunamis in 5 different countries. And what is striking in this graph is that Haiti stands out from the 5. And the only reason why Haiti stands out is that Haiti got up to 40 emergency medical teams by day 7 of the earthquake. So the response was huge, the response was quick. And the only reason it was that way for Haiti was because of the formation of these emergency medical teams by the World Health Organization. So compare and contrast that to Nepal, compare and contrast that to Kashmir and Indonesia and Iran. And you can see that the country with the most help and the earliest help was Haiti. So that is one of the things that the International Emergency Medical Teams Program has brought in disaster management: early and timely and effective response to any disaster in any part of the world. So what is the role of the anesthetist and any other clinician in disaster management? We're part of the emergency medical team, and there are a lot of organizations and non-governmental organizations that have made it a priority to respond to disaster. Of course, the most popular one, which I know that every one of us here on the webinar would know, is the Médecins Sans Frontières, which is Doctors Without Borders in French. So these doctors come together and decide to respond in a timely and in a coordinated fashion to disaster or emergencies in any part of the world. There's also the International Medical Corps, and there's MEDAIR, all right? So these are just a few of the medical teams that come together to respond to disaster and emergency anywhere in the world. So what is happening in our own corner of the globe? In Nigeria, we have a national body that is responsible for this. It's called the National Emergency Management Agency, but it was established in 1976 as National Emergency Relief Agency, and then later on in 1999, the name was changed, and then an act was produced with the new name, and it is designated to effectively coordinate emergencies and any disaster efforts that the groups like the road safety, Nigeria Police, the armed forces, and the civil defense will be engaged in. So it coordinates and supplements their efforts at managing any emergency or any disaster. Now, NEMA is represented at every state, is represented at some states and some local governments by the bodies called SEMA and LEMA, respectively. It operates within what we call a National Disaster Response Plan. And the first university, I believe for now should be the only university offering a course in disaster management, is the Ahmadu Bello University, Zaria. So they have a hotline, and the hotline is actually a mobile number, 08032000355. The Director General of this organization is Air Vice Marshal Mohammed, retired. I made some effort to talk to NEMA officials while I was preparing for this webinar, and there was a lot of things that were very striking to me. They couldn't provide enough information for me to understand how they engage medical professionals when there is a disaster or when there's an emergency. They couldn't tell me if they had a ready team, but what I know is that they had initially formed what they call a mobile intensive care unit. And the mobile intensive care unit is the health arm of NEMA that trains healthcare providers on emergency matters, resuscitation, and then they also they are part of their emergency medical team that goes out to the field whenever they are called for an emergency or a disaster. So their activities have not been very visible. And I think most of us will agree with us that what we really know NEMA to do is relief, giving out rice and giving out clothing materials and mosquito nets and insect and things like that. I mean, there has been a lot of issues with NEMA in recent times. One of them is their inability to harmonize what they're doing with all the other stakeholders like the Nigerian police, the army, civil defense, and road safety. There isn't a standardized protocol that NEMA can say, this is what everybody should do, and NEMA watches to see that everybody is doing it. So there is a communication gap existing between NEMA and all the other stakeholders. They have also been accused of severally, especially at the level of SEMA, that's the state, and LEMA. They've been accused of food and aid diversion by international bodies recently. There's also problems like not every state has an emergency management agency. So NEMA is not represented in every state. I know Lagos State has LEMA, very active, and then Anambra State also has a NEMA, but many states don't have that. So coming back to the description now of an emergency medical team, what is it? It is simply a team that's made up of local and regional anesthesia providers. We also have our colleagues in the surgical subspecialties. We have our colleagues in critical care, in nursing, emergency medicine, internal medicine. It also consists of the members of administrations of our hospitals, our major health facilities, and then local police and firefighting departments, their members, and of course, the members of the transportation, local transportation body. Everyone who is a member of the emergency medical team ought to have a license to practice. That's the ideal thing. And that's what works outside of Nigeria. So they have a license to practice in their country. And they're also, some of them are also licensed to practice internationally. They schedule regular meetings. They ought to schedule regular meetings to review and update strategies, allocate resources to hospitals, stock up in the event of a future disaster or emergency, and then simulate potential disasters and test their abilities and identify their limitations with a bid to improve on their services as a team. Local emergency medical teams are also responsible for formulating and using pre-designed protocols. So every EMT must have a protocol by which they operate to eliminate confusion, and then of course to channel resources and energy appropriately to any disaster zone. And of course, the members of that team should be prepared to cater and care for any team member who has a problem with their health and look out for each other to ensure that everyone is healthy and safe. Within this team, there are a group of people that are called first responders. So every EMT has within the team a number of people selected to be what they call first responders. And these first responders are usually anesthesia providers, that's us, and some of our surgical colleagues who go to make initial assessments of the disaster area on the type of disaster, the most common injury at the site of disaster, what would be needed for such a disaster, what would be needed for such injuries that have been seen. And then they are also responsible for activating the entire groups and committees that work with the emergency medical team to give the required care for the disaster victims. So now let's go to the specific role. So what is it in us for, in this matter of disaster management? What role can we say we play as anesthetists whenever there's a disaster? Usually our role is as the leader of the team, but sometimes we may not be the leader in the team, but many times we're often called to be leader in the team. And I think the reason why we're team leaders is that we are the ones that are the resuscitation gurus. We are the ones that are in control of the airway, the breathing, and the circulation, and these are components of resuscitation. So naturally, it falls back to us. Another reason why I think we ought to be the head of the team leading the emergency medical team is because of the vast knowledge we have in all the specialties. There isn't any specialty in medicine and surgery where you have the clinician knowing everything about his patients. It's only the anesthetist that is an all-rounder. And so that naturally, the role of being the leader in this team falls on him. We also have to go at incorporating in the we have a big role in the operating room as the anesthetist that would anesthetize the patients that will require surgery following a disaster. We have a role in post-operative care and in intensive care, and a vital role during transport of these patients. So we should know that we should be prepared to set up for anesthesia and or resuscitation in theater. We should be prepared to set up the recovery room, the high dependency area, the emergency room, and even sometimes the ICU. We should also prepare to build furniture in some of these areas because the hospitals have been devastated, they've been destroyed. We find that we join team members to build furniture, makeshift operating tables, makeshift chairs, makeshift theaters. These are things we have to learn to do, and we find ourselves doing with our colleagues when we get to the disaster site. Setting up oxygen concentrators and other equipments that are vital for us to save our patients from their injuries. Then it is also our responsibility to ensure that we have enough stock of drugs, enough stock of equipment, especially disposable equipment, and paperwork. And paperwork is very vital because documentation is vital in medicine. Whatever you did not document did not happen. And we are in the era where any little problem, people go to court. So we need to prepare ourselves and make sure that even in disasters, we make documentation of everything we do. Then it is our responsibility as an anesthetist to make sure that there are protocols. So we provide protocols on how everyone in the team would carry out their functions and ensure that people follow protocol. For instance, antibiotic prophylaxis, thromboprophylaxis, and of course, the World Health Organization surgical checklist. What are the other roles that we tend to play? Even though we are anesthetists, they're not our core areas, but we are expected to play them. We are expected to have skills as pharmacists. So we play some pharmacy role here by keeping inventory of all the drugs in our possession during the disaster, whether they are used, whether they are unused, and find out which needs to be stocked up. It's also our responsibility to ensure cold chain. Then we have the role of infection control, where we make sure that our equipment are cleaned, disinfected, and sterilized. We also have the role of laboratory. We're expected to to carry out simple tests like blood film for MP, use the HEMA-Q to get the hemoglobin levels, bedside blood group matching, and then bedside blood clotting. We're also expected to be managers within this emergency medical team, we're managing a small group of people, get people to do what they should do at the right time and do it properly, carry them along, encourage them. And then sometimes we're expected to teach, especially when we have our younger colleagues on the team with us. They want to learn a thing or two from some of us who have actually volunteered to be on EMT teams and have been to disaster sites. We can teach what we know to them. And then, of course, audit and quality improvement, which involves collecting data, because we have to ensure that we collect this data, because it's the data we collect from during our disasters, our management of patients during disasters, that will help us with future patient management in future disasters. So what are the pre-disaster strategies? In terms of the attitude of the anesthetist, one thing that we as anesthetists are good doing is we anticipate. So you know the way when you're working in theater, you always anticipate whether there will be problems. And if you anticipate what the problems are, you also prepare for them. That's the good thing about us. Remember, anesthetic considerations. When you have a case, the first thing that comes to your mind is, what are the anesthetic considerations? So we anticipate. We are thorough. Okay, so we are thorough. We think about this. You're in theater, you break your drugs, you label them neatly and carefully, and you lay them out. Okay, you're thorough. You are also hyper vigilant. You know that you have your anesthetic machine and your patient is connected to it. You can see the saturation, you can read the blood pressure, you know what the end-tidal CO2 is telling you, but you also use your eyes to watch the patient. So we're hyper vigilant. We don't just use machine, we use our eyes, we use our 5 senses to watch over a patient. We have apt problem solving skills. That's one thing about us. We know what to do. We can improvise where necessary. And we have sound decision-making capacity in crucial situations. All these skills that anesthetists have are things that make us prepare for disaster. So that is a plus for us. In addition, we must have a sense of discipline, dedication, empathy, and determination. Remember that disaster is something that has caused loss to people, so we always have to remember the human side of us and remember to show empathy to our patients. So now in the pre-hospital care, before the patient gets to the hospital, the first thing is that, remember, you're the one that provides the link between all the specialties present. So they follow your lead. At the scene of the disaster, try and take charge. You're the lead. Then you're expected to triage. Sometimes as the lead of the EMT, you don't do the triage yourself. You can delegate to someone else to triage the patient. And universally, there are color codes for triaging. There are 4 levels of triage. Patients who have minor injuries are coded green. Patients with non-life-threatening injuries are coded yellow. Where the injury is life-threatening, they are coded red. And when the patient is dead, the patient is coded black. So you need to be well-versed with triaging, resuscitation, and assessment. And you should have expected to take a lead in that. Now, this is a protocol for one of the most famous mass casualty triage system developed in the United States. It is called the SALT Mass Casualty Triage. And SALT is an acronym for SORT, Assess, Life-Saving Interventions, Treatment, or Transportation. And it was developed based on best available science and consensus opinion. And it incorporates all available triage systems in the world. So what is expected of you is that when you and your team get to the disaster site, you do step 1, which is to globally sort the patient into patients that have minor injuries. They are called walk. patients who have non-life-threatening injuries, but they are not minor. That's the wave or purposeful movements. And then patients that are still, they are not moving like the ones that have minor or non-life-threatening injuries. They are still, or they have obvious life-threatening injuries. So your priority in the assessment is to, when you have sorted them into these three categories, you should assess the patient with obvious life-threatening injuries first, before assessing the patient who can make some movements and has some injuries which are not life-threatening. The patient to assess last is the patient who has minor injuries. The second step of this assessment is assessing the individual patient. For those with life-threatening injuries, you have to control for hemorrhage, and then you check the airway and make sure the airway is patent and true. You do your resuscitation if you need to do compressions. And then if the patient is breathing, the next thing to do is to check for pulse, check if the patient is respiratory distress. Is there any major hemorrhage? If it is present, can you control it? Have you started controlling it? If the patient is not breathing and you have a certain patient breathing, then obviously patient is dead. You can't go ahead there. But then you can see the triad goes on and on and on. So your next role after the pre-hospital, which involves triaging your patient, is evacuation. And this is where your resuscitation skills come in handy. Remember that every patient in the site of disaster is assumed to have a cervical, a lumbar spine injury until proven otherwise. So we must place them on the boards, and we must strap them to the boards. We must also provide cervical collar for them to immobilize the neck, and then we must place them on the whiteboards and strap them appropriately to ensure that their spine is immobile and they are transported in such a manner. Then we have, after the pre-hospital phase, we have the hospital definitive care. For hospital definitive care, we must postpone all electives because the emergencies become priority. All the patients coming from the disaster site, they become priority. We also try to free up ICU beds so we can have space for those patients with life-threatening injuries that may not come into surgery straight away, but need to go straight to ICU. And for those who after surgery will go to ICU. Establish communication is important here, because while we're doing with a team in the hospital, we need to have a good communication loop with several units in the hospital, the blood bank, the ICU nurses and doctors, the emergency unit, because more patients may be coming in, and of course, with the hospital management, because they are the ones to give the go-ahead for the release of a lot of resources when they are lacking.
Yeah, hello, Dr. Onyeka.
Yes, sir.
Hello, sorry, you have less than 10 minutes. Sorry for the interruption. Thank you.
So this is level 2 EM type that we do. Okay, and these are some of the minimum standards that are required for operating type where level. This is a picture of the improvised theater. So on my right, on my left is an improvised theater. And if you can look, see a lot of bamboo holding the sheet. And on my right is a theater from Nepal. What is striking in both pictures is the level of improvisation that is here. We can see we're not using anesthetic machines, we're using oxygen concentrators, okay? So let us go quickly through the anesthetic considerations. There are problems with this patient. You don't know them, or you may know little about them. You don't know when they ate last, you don't know their allergy status, you don't know what medications they used before the disaster. You anticipate that there will be difficult problems with patients who have craniofacial injuries. Polytrauma patients have a lot of issues. The environment where they are coming from or where you are operating as an EMT, there may be no power, no lights, and you don't have your proper ventilator, that the fancy ventilator you use in your hospital, it's not there. So what do? Some other considerations are that you don't have enough manpower. You may be just a few of you on that team because some others have worked in other disaster sites and they are exhausted, or they passed on, they caught some infection, or they were part of the disaster and you lost them. Some are afraid to even be part of the EMT because they are not prepared. You also have deficiency of supplies. In a lot of these disasters, getting oxygen becomes a problem. And of course, the workload is high because of the number of casualties involved. These are some of the things now that we see. In place of your regular, you can't carry your regular mechanical ventilator to the field. So the portable draw-over, the old-time reliable draw-over apparatus is what is used commonly now. The oxygen concentrator is there, is portable, is used. Two drugs that play a key role in disaster management: ketamine for low middle income countries, propofol, where you have the downside is that if you have our colleagues coming from high income countries coming here, they'll be looking to see propofol. It's not that it's not available, but when you have a disaster, access might be limited. And of course, you wouldn't want to use it for patients who have trauma and severe hemorrhage. And then, of course, lastly, ultrasound, portable ultrasound is now a part of the armamentarium of the anesthetist in the emergency medical team for regional anesthesia during such. So in the recovery phase is more of the rehabilitation phase after the patient has been to theater or ICU. The objective is to help the patient get back partial or full function if possible. So there are issues we have to be looking at. A lot of these issues, especially amputees, will have issue with phantom limb pain, and you need to know to do some regional for them. And of course, in the days and the weeks and the months after the disaster, patients will keep coming in. For instance, a patient with a minor injury may get infected. Patients coming back into out of that disaster. Many of the casualties have orthopedic. Many of the casualties have orthopedic or plastic procedures done on them. Okay, so that's why we say portable ultrasound machines are invaluable for this disaster management, for being on the EMT team for disaster management. Why regional? It is simple. You don't need and recovery from general anesthesia may require general anesthesia, which may also require supplemental oxygen. It helps for post-operative pain and minimizes analgesic and opioid requirements and aids fast recovery. And of course, patients, you can easily move them about if they are pain-free. So in conclusion, anesthetists have not been actively involved in disaster management, and the time to contribute our specialized knowledge is now. And I would think that the right thing for us is to form disaster management teams in our respective hospitals so that we can change this trend and improve on the, reduce the mortality and morbidity that we find in some of these disasters. These are my references, and thank you very much.
Thank you very much, Dr. Tonia Onyeka, for that lucid presentation. By way of recap, we've been informed and also educated on the roles of anesthetists in disaster management. And this divided into resuscitation, pre-op care, up room, our role, post-op and intensive care, and also during transport. As anesthetists, we have this all-round impact. And also, we were informed also that we have to be trained, we need to make documentation, and also form protocols and some other rules in pharmacy, laboratory infection, etc. And she also mentioned the qualities or strategies. We need to anticipate, prepare, act. And she mentioned some additional qualities as anesthetist, which include discipline, dedication, empathy, and determination. Thank you so much for that highly informative presentation. Well done, ma'am. So the floor is open now to take questions. So please, if you have questions, kindly use the chat section. I haven't seen any question yet. So it means that either we're convinced or we are confused, but I know the presentation was well delivered. So we're convinced of our roles as anesthetists in disaster management. So I'll just give few minutes. If you have any questions, kindly indicate. And if we don't have any, we just quickly move on to the next session, which is a question and answer session, which will be handled by Madam President. So do you have any questions, please? The residents? Okay. So once again, thank you, Associate Professor Tonia Onyeka, for your presentation. So I hand over to Madam President. Okay, I think somebody just sent a question now. Somebody just sent a question now.
Yes,
okay, the question says, what is the role of ATLS in disaster management? ATLS, that's acute trauma life support. What is the role of ATLS in disaster management? Over to you, Madam.
Yes, of course, the role of ATLS is in disaster management is similar. It's ATLS simply what you do right there at the site. And I mentioned a few things that there's a lot of fast thinking, have to improvise a lot of things because the usual things you use to work in your normal relaxed environment are not available. So ATLS is big, is huge, and it has a huge role to play in disaster management.
Okay, thank you very much, Ma, for that response. Any other questions? Okay. Okay. One says, please, can we see the slide on references again?
Hi.
So can we see the slides on references again? Could you just project that?
Yes, let me share it again. Did we see it?
Yes, ma'am.
Okay, I can see another question. Someone says, is there any association for disaster management for anesthetists that can be contacted just like NEMA? I am not aware. I tried so hard. I know we have the Life Resuscitation Society of Nigeria, Professor Fakonle is the current president of that society. Apart from that society, there is no other association, to my knowledge, that can be contacted in cases of disasters. So that's the only association I know. I don't know if I answered that question for Dr. Jegede.
Yes, Dr. Onyeka, well done for a good job.
Thank you, ma'am.
We only have the resuscitation society, which Professor Fakonle has taken over from. But from your presentation today, I think it's high time we begin to look into that fact that we need to get into getting disaster management team of working with the emergency medicine personnel, including the traumatologists and every other person. I think it's high time that is done, incorporating everyone. I'm not sure if the surgeons have already, but at least we have to begin to build one where anesthetists have very good impact and role to play. That's my take about that. Thank you.
Thank you. You're right, because when I was preparing for this, you know, they said they will get back to me. NEMA says, okay. I said, I need this information. What do you do if there's a disaster? How do you get the doctors that come and work with you? They couldn't give me an answer except to say they have a mobile ICU. And their definition of mobile ICU is a team that trains and goes out for emergency response, which, you know, it doesn't tally, their function doesn't tally with the name, mobile intensive care unit. So obviously NEMA is incapacitated in that regard, and we need to be, like you have said, we need to drive this. We need to create the teams in our hospitals and help NEMA.
Yes, thank you very much, Madam Professor Tonia Onyeka, for that very detailed presentation. And thank you for the contribution or question by the NSA Vice President, Dr. Alagwe Briggs. Actually, this issue of having anesthetists incorporated into disaster management has been on for a while, for a long while. I remember when late Dr. Lawani Osunde was president, and we visited the then Minister for Health, Professor Onyebuchi Chukwu. It came up, and Professor Onyebuchi promised that when they were setting up the people that are going to be the first responders for cases for resuscitation and disaster management, that anesthesia was going to be fully involved. But I don't think that program saw the light of the day. So I agree with all the assertions that it's about time we take it up as an important aspect of our work, because right now, Dr. Onyeka is right that there's no real laid out acute care team in the NEMA. I had a recent interaction with them too last year when my husband needed emergency services, and it was nothing to write home about. It was so terrible, so disjointed, and all that. I even had to call on the national director. I don't know, what do they call him? And there was nothing entirely. They had a nurse who I thought she was a NEMA staff until she told me that she actually has, what she had was a ventilator, which she loans to NEMA to carry a critically ill patient onto in the aircraft when they need to transfer patients from one place to the other. And it was not a really well laid out plan. It was so difficult. Eventually, we couldn't even assess it, and unfortunately, he couldn't even benefit from it. So I agree that we need to put a structure into place that will interface with all these areas. And I agree that the Life Resuscitation Society of Nigeria is there. And in fact, why the name was changed to Life Resuscitation Society of Nigeria was because when it was going to be, it used to be Resuscitation Society of Nigeria. And then they said there was already registered a Resuscitation Society of Nigeria and a Resuscitation Council of Nigeria. But we don't know where they are. They are registered, but we don't know where they are functioning. So those are the issues. And I agree that we need to strategize, and we need to put it on a front burner, on a way forward to be able to articulate all these ideas into a form and a structure that we can actually float as anesthetists. Thank you very much. Those are my thoughts on that issue. Thank you so much. I want to also respond to some comments in the chat box, if I may. May I? There are some people asking for the presentations for previous videos and slides of previous presentations. Now, I want to say that all these are on the NSA YouTube channel, and you can log on to it. You can subscribe to it when you view, so that subsequently, when new videos are added, you can be notified. I don't know. Over to our moderator for the day. If we are done with this session. Thank you very much, everybody. Hello, Dr. Muyiwa. Hello, Dr. Muyiwa, is he around? Our moderator for the day. Hello. Okay, there are some requests also for the presentation to be sent to various emails. Can we ask from Dr. Onyeka, if we do have the presentation, the slides, can we be free to share it with the participants? Professor Onyeka. Hello, Professor Tonia.
Yes, Prof. Yes, Prof.
Yes, if we can.
Yes, Prof. Please go ahead and share. I have made it available.
Okay, thank you so much. So we can actually ask the NSA secretary to put it on the NSA platform, and also to send to emails of those that have requested. Dr. Okoje, please, would you be able to do that for us? Hello, Dr. Nkechi, are you around?
It can be shared on the screen. We are compiling everything together. We compile and share.
Let's put the presentation on the WhatsApp group pages and the page on the the Telegram page, if we do have it. Yes, thank you very much. So our moderator, are you there? Can we move on to the next part of the session? It's 4 o'clock. Hello, Dr. Aliyu. I can see you. Thanks for joining. Hello. Is Dr. Muyiwa still with us? Do we have the permission of the moderator to move to the second part of the session?
It appears he's been cut out.
Oh dear.
Perhaps network problems. It's not.
Okay.
Yeah.
Okay. So thank you, El. Thank you, everybody. Thanks for joining. We have a good number of participants today, so we can actually take the second part of the presentation. What we want to do today is to take model questions. If we can take model questions for the exams, questions for primaries, for membership or part 1, and for part 2 fellowship exams. Ideally, we wanted our participants to send us questions ahead of time so that we could prepare for it. But up till this morning, I was not informed about any questions. So we have the next 20 minutes to discuss these questions. If there are any questions from the participants that we can discuss, then we'll do that. And also we have amongst us some of the examiners who are partners and have been following closely what we are doing. If they also want to discuss anything that they feel could be of benefit to us, please feel free to do so. Thank you very much. Hello, Dr. Koji. Do you have any, did anybody send in questions to the NSA email? There is a question I've seen some questions now. Okay, all right, let's start with, I've seen 3 questions. The first question from Dr. Ama, it says, please, what is the difference between adverse events and critical incidents? This is a part 2 question. The second question is, how will you set up a virtual conference? This is a part 2 question also. Then there's another question to me directly from Dr. Yemisi. Permit me to read it out to everybody. It says, good evening, Ma. It says, please, how do we assess pain in an ICU patient? The fourth question we have is, what is new about coronavirus and the current, and the current beliefs? That's a part 2 question. All that. Okay. Thank you very much for all these questions. So we're going to take the questions one after the other. I don't know, Dr. Briggs, are you there? Hello, Ma, Dr. Briggs, Madam VP. Madam Vice President, NSA.
I'm here.
Okay, have you seen the questions? Is there anyone you would like to discuss?
Okay.
There's one, the first one, the difference between adverse events and critical incidents. It's a part 2 question. The second question, how will you set up a virtual conference? Part 2 also. The third one, how do we assess pain in an ICU patient? I guess this can be membership part 1 or part 2. Then the fourth question, what is new about coronavirus and the current beliefs? Is part 2. Then I've just seen another question again. Is for fellowship. How do I go about a question that says, discuss the current issues on COVID-19? I think it's related to the fourth question. We can take the 2 questions together. So if there's anybody who can discuss any of them, we'll take it turn by turn.
I would deal with the first one, Madam President.
All right,
Thank you
please.
very much.
Go ahead. Thank you.
I would want to suggest that Dr. Onyeka takes the question on pain, because
Yes.
especially is pain and palliative care.
Yes, that's true. Excellent.
So considering the first question, well, it's quite straightforward, really. If you consider the simple English language implication. Adverse events means that it's something deviating from normal, but it is not life-threatening. Critical means it is truly critical and life-threatening. So that's just the simple difference. It's quite straightforward, like I said. So you can think of all those things, that do not relate to critical organ impairment, organ disability, organ dysfunctioning. So those ones can be taken as just adverse events. But when it begins to relate to organ dysfunction, either respiratory, cardiorespiratory, renal, neuro, then you can call it a critical incident. So I hope I've been able to.
Yes, I think that's basically it. I think that's basically it. They are just about the same thing. It's just the severity that differs. An adverse event, you can have an adverse drug reaction. A patient can have urticaria, rashes, or whatever under anesthesia. Okay, and it's an adverse event. Okay, but then when it becomes a critical incident, it has progressed into, for not just urticaria, it's now having hypovolemic shock, it's probably having a cardiac arrest or something. It then becomes a critical incident. So, and critical incidents are life-threatening, just like Dr. Briggs said. And critical incidents usually are supposed to be reported. In the standard practice, in most places, once you have a critical incident, like a cardiac arrest, like somebody having a life-threatening bronchospasm under anesthesia and all that, you have to report it. And some hospitals actually have a critical incident reporting form or something like that. And then some hospitals too do a critical incident audit at intervals. Some do it quarterly, some do it twice in a year, some even as frequently as yearly. They do audits of critical incidents and they report it for the hospital. And from those audits, they can decide or they can have conclusions and resolutions and things that they may need to change their practice, or they may need to modify their practice in their hospital. For instance, if they notice that the incidence of cardiac arrest under anesthesia seems to be increasing in that hospital, they may try to find out, adduce a reason for it, and then go ahead to say, okay, because of this increased incidence of cardiac arrest, this is what we are going to be doing now. Patients must be screened for this or that. Patients must not be subjected to anesthesia if they are not stable, even if it's an emergency, and so on and so forth. So, like things like drug interactions or drug reactions or adverse drug reactions can also be reported. Hello. Hello, am I communicating? Hello. I think we've said enough on, yes, we've said enough. Yes, we've said enough. We've said enough on the critical incident. So let's move to the next question. Dr. Tonia, Associate Prof. Tonia Onyeka, would you like to take the question on ICU, pain assessment in the critically ill patients?
Yes, ma'am. Yes, Prof.
Thank you, please.
Oh,
Go ahead.
okay. So yeah, so a number of us have been, confused as to whether we can effectively assess pain in patients who are in the ICU, whether they are conscious or they are unconscious, whether they are intubated or they are not intubated. And yes, we can assess pain in patients in the ICU, whether they are intubated or not, whether they are conscious or not. Most of the scales that are used in the ICU are majorly behavioral scales, okay, for obvious reasons, because many of the times our patients can't talk and are deeply unconscious. So behavioral scales. So some of them are like you have the behavioral pain scale, you have the critical care pain 2, you also have the FACES. The FACES scale. FACES is an acronym, is the acronym for face, activity, legs, and I can't remember what the E is, expression. So you have those two, but the very popular one is the behavioral pain scale. It has 3 items. It has facial expression, upper limbs, and then compliance with ventilation. It's similar to ABGA, and each one has a score of 1, 2, 3, 4. The score of the lowest score possible with the behavioral pain scale is 3, which means no pain. But the highest is 12, which is the worst pain ever. I would encourage us to go and read up those scales, some of those scales, like the behavioral pain scale. Now, management of pain, also the treatment, what is advocated is multimodal analgesia. So multimodal analgesic practices is that you don't stick to just one drug. A combination of opioids and non-opioids after you have assessed the patient will do the patient a great deal of good. Thank you.
Thank you very much, Dr. Onyeka. That was excellent. In 2018, I gave a lecture at the Critical Care Society conference in Africa that was in Egypt. I gave a lecture on pain management in the critically ill patient. I'm going to look for the slides and possibly put it on the YouTube channel. But basically, Dr. Onyeka has done everything. She has said it all. So all you need to do, let's know that there are so many pain management, pain assessment tools for the critically ill patient. And even for the unconscious patients, there is even pain scales that incorporate FACES pain scale, the OSHA scale, and it's called the integrated pain scale that you can use for assessing pain in the critically ill patient. And yes, pain is a big problem in the ICU patients, and I will share those slides once I get my hand on them, or I will send it to the NSA secretary so that they can send it to the email, at least for those that have participated in this meeting. And for whoever who asked it was, I think it's Dr. Yemisi. Okay, we'll send it to Dr. Yemisi. Thank you very much. Let's move on to the next question, please. It says, discuss the current issues on COVID-19 as a part 2 question. Is there anybody that wants to discuss it? Is there anybody that wants to discuss the current issues on COVID-19? Well, let me make an attempt, but I hope that next time the questions will be sent ahead of time so that it can be tackled, more pragmatically and in a detailed form. But basically, for a part 2 question like this, if you're asked to discuss current issues of anything, especially something topical like the COVID-19, which is a pandemic, you need to say, what is COVID-19? You need to be able to say there is a coronavirus disease that was described in December 2019 in Wuhan, China. You need to talk about when it was described and declared to be a worldwide pandemic in February 2020. Then you need to say the things to do with the different rates in different parts of the world, and specifically in Nigeria. Since we are Nigerians and West Africans, we need to talk at least things about Nigeria, Africa, and the sub-region, specifically countries that had issues or have had issues with it, and like South Africa, like Nigeria, like Ghana. You need to discuss that. You need to also say some notable people that have been claimed by it or suspected to have died from COVID-19. Then the current thing, the most burning issue now is the coronavirus vaccine that is available. You need to say that it started all over the world in December. By January, UK and US had started, and that it arrived in Nigeria in March 2021, and it was kicked off in Abuja, and the notable persons have taken it, and states all around the place have taken it, and that many anesthetists have taken the vaccine. I know some of our members, like General Gumbi, has had his shot. I've had mine. Many of us have had ours. And you need to say the types of vaccines that are available. At least now we know that there are four vaccines, 4 main types based on the manufacturers. You should be able to know the different rates of efficacy for the different vaccines, and also for the one that we have in Nigeria. In Nigeria, what we have is the AstraZeneca, and the rate of efficacy ranges from 64% to 90%, depending on what you're talking about. Excuse me. And then you need to know how it is given. In Nigeria, it is given, the first dose is given, and then 12 weeks later, the second dose is given. And then you can talk about the side effects of the different vaccines, and the common, the topical issue of the side effects of the AstraZeneca is the issue about the hemorrhagic disease, which they say is 1 in 100,000 people or 1 million people. It's rare, but for the person that dies, it's 100% mortality. So basically, those are the current issues on COVID-19. And then you need to say that now taking the virus is a topical thing, and people are encouraged to take it. And even though there are anti-vaxxers and vaccine hesitancy, which is very high and very rampant, especially in a place like Nigeria, that we can prevent the vaccine hesitancy by we being leaders and leading by example, by as frontline workers, as anesthetists, taking the vaccine ourselves and publicizing it on social media and talking to people, religious groups, communities, and online how to take the vaccine, and still to continue with the preventive measures, uh, social distancing, regular hand washing, use of sanitizer, and well, when you sneeze into your elbow, and generally keep healthy, hygienic practices. Avoid people grouping together in enclosed environments. Basically, those are the current issues I can remember for now off the cuff. Of course, there are more things. I don't know if there are any things I've left out. Can anybody talk to us about it? Aha, then you need to talk about the travel restrictions, the issue of traveling. If you need to travel, you need to quarantine. You need to take a, you cannot travel without a negative COVID-19 test. And if you're traveling into Nigeria upon arrival, you must register to get another test 7 days post arrival, and all that. Basically, that's it. And also the issue that now you may need to show your coronavirus vaccine certificate before you can travel. The vaccine passport. That's what people are talking about nowadays. So I don't know. Have I done justice to it? Somebody asked about current beliefs. Well, there are myths and misconceptions about COVID-19, and you can talk about it. Like some people don't believe it exists, like some people don't believe that it can be transmitted from one person to the other, and all that and all that. Like some people are worried why getting a vaccine so soon and so early. We've been with so many other diseases for years, and there was no vaccine for those diseases. How come there's COVID-19 vaccine in less than a year? But again, those ones have been disproven. And of course, there are also some conspiracy theories. You can talk about that one too. And also say that, of course, those have also been disproven because scientifically, COVID-19, coronavirus is an mRNA virus, and we know that it's not such a strong virus. It can be easily denatured, easily destroyed, but it's also because it's airborne and air droplets and inhalational, it can also travel very fast and infect large groups of people. So that's what I can say for now for about current issues on COVID-19 and current beliefs as a part two question. Thank you. Any comments or any inputs from anybody?
Prof, Prof Ma, you've
Yeah.
done well. I just remembered something too. I
Okay.
remembered the mechanism of COVID chest. What are the theories around COVID chest?
Well, yes, that is also a topical issue.
Mm-hmm.
Yes, the COVID-19 chest is more of an ARDS, and the findings are classical on CT scan and on chest X-ray. You have widespread opacifications, and what is even being talked about now is that there's a third wave of COVID-19 that does not have the classic signs and symptoms, no coughing, no sneezing, probably no fever. The patients may present with just joint pains, and they may just have joint pains, and then they may have maybe some general body weakness, and then they will just come down with a pneumonia, and within a short time they are dead. So I had a patient on Monday, Tuesday morning actually. My attention was drawn to him, and then when I saw him, I said, "This case is very bad. You need to transfer him. He needs a ventilator. He needs a proper ICU." Well, we were able to set up one of the COVID-19 ventilators that was donated to that hospital, and by the time we put the patient on it, it didn't last 5 minutes, and he was dead. So just that morning, they were telling me, no, it's not COVID. They have done the test 2 days previously on Friday or Saturday, and that day was Tuesday, and it was negative. And then when I talked to the CMD, I said, this thing looks like COVID-19. This breathing is irregular. The CMD said, yes, he shared the CT scans with me. He showed me. He said he saw the CT scans the previous night. It was classical. But he didn't want to tell the relations because it was a very big man and a member of House of Reps and all that. So, but within 2 hours that we spoke, we put the man on the ventilator and he didn't make it. So there are there's a write-up on the 4th of April that COVID-19 is changing. There's a new type of COVID that we need to have a high index of suspicion, and it's often not found in nasopharyngeal and throat swabs, which is the common place that the swabs are taken. So that they are now thinking that they should do a gastric washout to be able to get the virus, because the throat swabs are negative most of the times, and as well as the nasopharyngeal swabs. So these are the issues. So I guess, well, let's move on. We need to keep about COVID-19. You need to check it up every day, because every day there's something new. Every day there are new issues coming up. So we need to check the literature every day. Thank you. Yeah, thanks so much for that contribution. Any other? Let's move on to the next question, please, if we can. Hello?
Excuse me, ma'am.
Yes, please.
It's also important at part 2 levels for the candidates to remember about the various trials that have been conducted, like the solidarity trial and then the recovery trial by WHO, and what those trials actually recommend in the management of these patients. So it's also important for them.
Yes, that's true.
The antiviral, anticytokine drugs, the medications that are being updated and used every day.
Yes. The treatment protocols are changing. Initially, they said remdesivir, and even in Nigeria here, there's a trial that was done or is still being done by Professor Chris Bode and colleagues at LUTH. And they are saying that we can actually use our age-old known drug. What's the name of this drug now? This drug that we used to use for filariasis. Ivermectin. It just escaped me for a minute. Yeah. So that ivermectin is effective, and then some people are saying that it's not any different from in other cases, whether you use ivermectin or not. So there are many controversies, many issues. Yes, thank you very much for that contribution, Dr. Job. I quite agree with you I think if there are any part 2 candidates here, they should just go and write their own essays about current issues on COVID-19, make it detailed and learn it. Because, yeah, it's a very topical issue. And yes, it's an exam favorite from since last exam. So even for part 1, it can come up or membership in the oral section. Even in the essays, I don't know. So let's move on. We've done the first 4 questions. There's another question. This question says, the anesthetist's role in reduction of maternal mortality. This is a part 2 question. I don't know who wants to talk about that. I've been talking a lot. Then there's another question by Dr. Obilo. It says, any need for different treatment protocol or regimen? Okay, I guess he was asking because of my comments about the phase 3 new brand of COVID. The treatment regimen and protocols remain the same. They remain the same. Use of antiviral agents, use of cytokine for drugs for the cytokine storm, use of steroids, use of ivermectin, and all that, and antibiotics. Of course, we still use our good old antibiotics and vitamin D and all that. So let's take this question on what's that? Role of anesthetists in reduction of maternal mortality. Hello? Can anybody attempt it? This is a popular question. I've actually seen it. I've actually seen this question in part 1 or membership in the past. And I think it's in the related specialties paper. Yeah, it also comes out in part 2 also. Part 1 membership and part 2. Can anybody attempt it? Where are the obstetric anesthetists on board? Dr. Onyeka, can we poke you? Hello, Tonia, can we poke you? Reduction of maternal mortality.
I know that if I have to answer the question, the way I would approach it is, I would first of all think about the causes of maternal mortality.
Exactly.
And then we'll go from there. So I know the commonest cause is hemorrhage, okay? Postpartum hemorrhage. And then you are thinking of what you can do as an anesthetist to prevent or reduce the occurrence. The use of tranexamic acid is very key there.
It's topical.
There's actually a trial. Yes, topical. There's a trial that was done recently, 2019, about it. So that's how I would go. Other causes, sepsis, puerperal sepsis. Then that's the way I'll go. I'm just trying to remember the causes. After listing the causes of mortality, then how, as an anesthetist, role of regional anesthesia for eclampsia, that's another cause.
Yes.
So regional anesthesia, role of regional anesthesia for some of those causes, how it will help reduce mortality. That's how I will approach it.
Thank you very much. Thank you very much, Dr. Onyeka. Actually, yes, the background is to say that anesthetists play a pivotal role. Anesthetists play a pivotal role in the reduction of maternal mortality. And their role cannot be overemphasized, but also it's very important because maternal mortality, the prevention of and reduction is a team-based approach. You have the work of the obstetricians, you have the work of the anesthetists, you have the work of the hematologists, because what the current issues now, they're talking about comprehensive obstetric maternal and newborn care, CMONC. That's the aim thing now. So, and it's a three-leg approach. So the anesthetist's role is key in securing whatever the other people, the obstetricians and the hematologists may be able to do. Hematologists have more role in blood transfusion and all that, blood and blood products. The obstetricians have more role in terms of early delivery by giving, providing facilities for cesarean section and also facilities for the newborn. But the anesthetist is there all around the place, from pre-op, intra-op, and post-op, and even those that don't need surgery but need critical care in the intensive care units. So yes, you have to talk about the big five causes of maternal mortality. And yes, of course, Professor Onyeka has said it. You have to talk about hemorrhage. You have to talk about prevention of sepsis. You have to talk about eclampsia, preeclampsia. You have to talk about
Abortion.
abruptio. Yeah, abruptio. All of those are under hemorrhage. All of those are under antepartum and postpartum hemorrhage. They are all subsumed together as hemorrhage. So when you now take up these causes of maternal, the major causes of maternal mortality, then you begin to talk about them one by one. And as you now say what the anesthetist does, the timely input of the anesthetist will prevent a woman who was bleeding from any of the causes of antepartum hemorrhage. Is it abruptio? Is it placenta previa or whatever, from dying? Because if the anesthetist is there, it's going to ensure that they get the appropriate type of anesthesia for the appropriate surgical intervention, cesarean section or whatever. And once the anesthetist is on board, it's going to also ensure that adequate blood, adequately prepared blood is transfused and all that. That's one of the roles. Another way is in the obstetric, is in the eclampsia, pre-eclampsia and eclampsia. What do? We ensure that the blood pressure is controlled. Before we choose an appropriate anesthetic technique, and we'll make sure that the patient gets it. And if there is HELP syndrome, we manage it also appropriately. And of course, for sepsis, a lot of times the sepsis may need critical care, and the anesthetist is there at hand to provide care in the intensive care unit. And where there are no facilities for intensive care in the particular hospital, the anesthetist will stabilize the patient and then refer appropriately to a facility where they have adequate care. So yes, the anesthetist is key in the prevention and reduction of maternal mortality. I think we've discussed that adequately. We have Dr. Amusan Omodele wants to say something. I see a hand up. There's another question. How will you set up an ICU? Do we hear from Dr. Omodele Amusan before we answer the question? You wanted to say something. Oh yes, Dr. Sars has given us the five causes, the big five: hemorrhages, infection, toxemia, and pregnancy, and abortions, and then others. Yeah, that's the mnemonic is HITAL. Yeah, thank you very much for that, Dr. Saheni. And then Dr. Koji made a please, sorry, can you mute your speaker if you're not talking, please? Or Dr. Koje, can you mute the person that is coming with this extra noise? So Dr. Koje says that we play roles in resuscitation, airway management, providing safe anesthesia for cesarean section and labor. Yes, thank you. Thanks for that. That's very concise and accurate. So I think, yes, there's also blood products for transfusion and ICU care. Yes, thank you. I think I touched on that. Thanks so much. We have another question from Dr. Oronsaye Omorege. Yes, please.
I
Yes.
also think that it's also nice to start the discussion from the angle of defining what maternal mortality is, the causes,
Yes.
and then the various roles that we play in reducing deaths in women who are pregnant or in the preparing room. So that
Yes.
definition, it starts the discussion, and then the causes. And like you said, airway management, critical care, working in resuscitation, then the high dependency units in obstetric care, even the concept of the essential obstetric care anyway in environments where you have these high rates of mortalities. These are to start it, and then you arrange it in a much more concise form, and the discussion will just flow.
Yes. Thank you very much, Dr. Job. Yes, in writing an essay, it is key for any essay that you define the concepts that have been elucidated or that have been mentioned in the question. So for this question is maternal mortality. That is the key question. So I think if you're writing it as an essay or if you're talking, you should be able to define what is maternal mortality. And also, Dr. Briggs said we should state the incidence of maternal mortality in Nigeria. If you're defining maternal mortality in Nigeria, please also state the incidence. Then we have a question of how will you set up an ICU? And I'm reliably informed that we took up the question last week. Well, for the benefit of those that were not around last week, setting up, how do you set up? It's a management question, and it's a common question for membership and for Part 2 fellowship. Setting up of anything, it might be an ICU, it might be an obstetric anesthesia unit, it might be a pain clinic, acute pain setting, acute chronic pain clinic, or whatever. Setting up, you have to first define what is it that you've been asked to set up. So what is an ICU? You have to say what an ICU is. You have to say the types of ICU. So an ICU is a specially designed, especially equipped part of the hospital where patients with critical life-threatening conditions are handled. And it is the standard size of the ICU is that 1 to 2% of the acute beds in the hospital should be designated for ICU. So if it is a 200-bed hospital, it means that you should have 2 to 4 bed ICU. It's for a standard general ICU. And then the location of the ICU, it should be accessible, easily accessible to the areas of emergencies, the A&E and the theater, the obstetric unit, and all that. Then you talk about the design of the ICU. There are different types of designs, the open ward system and the cubicle system. Then you talk about the levels of the ICU. Then level 1. Please, can you mute yourselves, please? Then there is level 1, level 2, level 3 ICUs. Then, yes, you have to also arrange it in terms of what do you need to do to provide in setting up. You need to provide the manpower, the equipment, and the machines or the infrastructure, manpower, equipment for listen. So it's MMM or money. That's the mnemonic for it. Thank you for this, Dr. Nkechi. So you need to have the mnemonic for the things to provide when setting up. So for the ICU, you need to know, you need to know. Hello, please, can you mute yourself? Please, if you're not the one talking, kindly mute yourself. Okay. So, so you need to know the manpower. That's the staffing. For the staffing, you need to know the doctors. You need to know the nursing staff. How many nurses you need? You need to have at least one nurse per patient per shift, and then some nurses to take care of off-duty days and all that. Then you need to know the equipment that are necessary for the ICU. You need to know how the monitors, the ventilators, the oxygen supply systems, and the beds, the types of beds, suction, all those things, and even the size, the design, the size, the bed space, the size of each bed space per square meter. It's important for the ICU. Then you need to know also the equipment, other equipment that you need for special care of patients in the ICU. Apart from ventilators, you may need other life support equipment for the patients. So, and then of course, you need to talk about the things to be done in the ICU for patients and who does it. The regular monitoring, who does what. You need to know about that. So I think setting up, you need to do, yes, thank you, Dr. Nkechi. You need to, before you start, you need to do a needs assessment, and then you need to do a budget, like what do you need to be able to set it up, the financial implications if you're setting it up from the scratch and all that. And you need to be able to defend your budget. You need to be able to defend your budget. Yeah, so I think we've discussed this last week. So please, we have just 12 minutes to the end of this discussion. There's also another mnemonic that uses S: tough, staff, and service and size. Okay, that's interesting. I was seeing that one for the first time. So SSSS, 4S: stuff, service, staff, and size. I guess stuff we mean by equipment, staff, that's the manpower, the service, that's the facilities, the things that you do, and the size, of course, that's the design. Oh yes, that's cool. That's a cool one. Thank you. Then don't forget about auditing of the ICU for quality control. Thank you, Dr. Obiwuru, for that input. Dr. Vin Obiwuru, thank you for that. With that, if you're writing about setting up an ICU, you should not forget about auditing of the ICU. Okay, thank you so much. Thanks everybody for your input. I think we have attended to the questions that we have on ground. In the absence of any other questions, on a general note, please, for those that are doing membership and part 1, you know how to answer short answer questions different from how to answer essay questions. They are completely different, and then know the difference between describe, discuss, and or list. These are all different. In discussion, you need to write an essay to go to town, whereas describe, you just write the points. Well, and list is just a numbered list, 1, 2, 3, 4, 5, like that. So we have to be concise and accurate when we're asked to discuss, to write a list. For discuss, you can go to town. Then, hello?
Yes, Prof.
Yeah, so and for those that are doing MCQs, some of the MCQs have been done for the national. The one for the West Africa, I think, is coming sometime next week. But MCQs are now single best answers, so you need to know it's one answer that is the best correct answer. It's not like multiple choice. Oh, sorry, Dr. Ayanate, we nearly forgot. It says that setting up a virtual conference has not been discussed. Dr. Sayeni has given us a link to materials for setting up an ICU. So you check in the chat boxes and follow the link, and then setting up a virtual conference. Okay, setting up a virtual conference. This is easy. This one of the good things that COVID-19 has brought for us is this virtual conferencing option or facility. We are now able to discuss from all over Nigeria. All of us were on this chat, and it's a virtual conference. We are calling it a Zoom meeting. Zoom is just one of the platforms that you can use to set up a virtual meeting. By virtual, what do we mean? What do we mean by virtual? Virtual, that is using the internet. We are not doing it physically. We are not seeing face to face, but we have facilities online to be able to have this meeting. All of us, over 106, have been interacting together almost 2 hours now, and we are discussing real time, one-on-one, as if we are seeing face to face. So this meeting, this webinar is like a virtual conference. Last year, for the first time in the history of the Nigerian Society of Anesthetists, we had our first ever virtual conference. So I wish Dr. Queenette Kalu was here, because she was the chair of our virtual conference organizing committee. I will have asked her to talk to us about this. But basically, a virtual conference means that everything is online. There is no physical component. And nowadays we're having the virtual conference combined with the physical aspect. And that is called a hybrid. That's called a hybrid conference. And that one, it involves, so how do you create a virtual conference? One, you prepare the speakers for the conference. You set up the topics and prepare the speakers. Like for this, our virtual webinars, we have a coordinator or an organizer, Dr. Briggs. Maybe Dr. Briggs will talk after I finish talking. So for this, our webinars, she has been the lead person. So what she does is to set up the speakers. So she set up the topics for us, and then she got speakers, because every good conference, the backbone of every good conference is the speakers. Even so, in virtual conferences, the backbone is the speakers. Then the next thing is the technology to set it up, to bring it up online. So we had to get a host to host. Our technical components is being handled by this company, Kovani. They are giving us the support using Zoom. We are using Zoom. We had the option of using WebEx, Microsoft Teams, Google Meet, and all that. But because we are conversant with Zoom, in the heat of the COVID-19 pandemic, we used Zoom to do the training on coronavirus in April, May, and June last year. So we have been tested and tried in the using of Zoom. So we opted to use Zoom. Hello, Dr. Ayanete, are you with me? Hello, am I answering your question?
Yes, ma. Yes, ma.
Okay.
I am, ma. I'm with you.
Okay.
Thank you, ma.
So the step one, I said preparing the speakers. Step two, I said the technology, the technical components to bring it online. Then the step three is structuring a virtual event agenda. For our event agenda, it was also handled by the NSA ESCO. Dr. Briggs was coordinating, Dr. Koje, Dr. Yakubu, all the ESCO participated very well to give the structure, to get the speaker, excuse me, to get the speakers, get the moderators, so you get the agenda. So they made the timetable. The agenda is the timetable or the program of events. So that's week one, we have this lecture moderated by this person. Week two, we have this lecture moderated by this person. And that's how now we are on week 8, lecture by Dr. Tonia Onyeka, moderated by Muyiwa Rotimi, and then this question and answer session. That is the third part. Then the step 4 is the creating the real-time interaction online. So you see, when we're about to start, our NSA secretary, Dr. Okoje, has been on the top of her game. She starts the meeting, make sure everybody is here, puts people as hosts and co-hosts, and controls the interaction, the flow. If people are talking when they're not supposed to talk, she mutes them or asks them to mute themselves. And if people have not come online, she will call them and say, you have to talk next, so come online. Or she'll call me and say, we've started, ma. We have started, we are waiting for you to say the opening remarks or something like that. So that is step 4, the real-time online interaction. That's the step 4. Then the step 5, once you've done 1, 2, 3, 4, you're set to go. You get it going and you start. Just like we are on now. We've been on now for almost 2 hours. It's 4:57, and we're still on. So make sure that everybody has internet connection. Everybody puts data on their phone or on their device, and then listen. So you can check it, go online. Dr. Onyeka is just giving us a link. Hello, please, can you mute that, somebody? There's a link from Dr. Onyeka. It says, it's on the chat box. Please, go on to it, Dr. Ayanete, and everybody that is interested in this topic, follow the link and read more about it, okay? So,
Yes, ma'am. Thank you, ma'am.
There are also other things that you can learn how to do, how to share your screen when you are online and giving a presentation. Like 2 weeks ago, we had issue of share your screen and don't share your screen, make this host and don't make this host. But luckily, we are able to overcome it subsequently. Because before you want to speak in an online platform, you need to have your technology right. You need to have a technology assistant or a technical person who can say, use this internet modem or use the other modem, or MTN is not working well, use Glo or use Airtel or use Etisalat, just like that. And you need to have another device in case your device plays up with you. When I'm on my phone, I have my desktop, my laptop standby. And when I'm on one phone, I can have another phone standby, because technology, just like any other thing, it can go wrong, and it will go wrong when you least expect it. So you always need to have backup, okay? You need to charge your device very well, have a battery or a power bank, and have facilities for power supply. Like my power supply in my house just went off now. Everywhere is dark. I have to use a torch and all that. So that's it. I hope I've answered your question. Hello? I hope I've done justice to your question. Okay.
Yes.
Okay. So okay. So check the links by Dr. Onyeka and see if it will help. Okay.
Yes.
So
I appreciate
the
Madam.
access, your line is vibrating, Dr. Ayana. So we're about to round up. Let's do some quick housekeeping. Please, you are going to be the Nigerian Society of Anesthetists has engaged the services of an administrative and membership manager who is going to be helping us to update our membership directory as well as get new members and also attend to other administrative duties to support the secretariat and the other ESCO. Please, if you get any call from him, do not be disturbed, do not be afraid. He's going to be introduced to us officially. The secretary is going to do an email that will be sent to all the members that will have their contact. And we're also going to put it on the WhatsApp groups. His name is Mr. Francis Emeka Dinwoke. And then okay, about the Zoom meeting, I mean, the online meeting, there's a chat. Let me say it before I forget it. Dr. Briggs, thank you for that. So you need to form the conference organizing team, assign different roles to different members, pre-conference test run, yes, and then that's from Dr. Venetius. Then from Dr. Briggs, he says you need a good background, silent environment, appropriate dressing, break time for extended meetings. Then and the NSA WhatsApp group, the second group is full. So last week, the third group has been formed by Dr. Yakubu Momosani, and we are ready to admit new people into the group. So we are going to, would like you to please oblige us by paying your membership dues, 5,000 Naira for residents and 10,000